Join me for the invocation with Chaplain John Gerhardt.
Thank you very much, Dr. Malone. Would you stand with me, please, for our invocation? May we pray together. Lord our God, as we begin this new year, we are reminded by the Scriptures that he who humbles himself shall be exalted. So we give you thanks for the tremendous recognition that has been granted our hospital system by the Magnet Committee, as they have affirmed our high calling to humbly serve the healthcare needs of our neighbors with great excellence and even greater compassion. May you grant us grace to continue to pour ourselves out in the service of others, that we all, with humility of mind, might love and serve all those who come to us in need, loving our neighbors even as ourselves. These things together we pray. Amen.
Amen.
Let's do the Pledge of Allegiance together.
Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
We'll now call the meeting to order of the Sarasota County Public Hospital Board on January 21st. And this is an announcement we make each time. Any citizen desiring to address the hospital board should turn in a speaker card to the board secretary. If the citizen comment pertains to an item on the agenda today, the comment will be heard early in this meeting. Otherwise, it will be heard toward the end. Speakers are asked to limit their comments to 5 minutes. Vendors, suppliers, or other persons seeking hospital contracts awarded on a competitive basis are reminded that their ability to address the board may be restricted by the terms of the invitation for bid, request for proposal, or other purchasing criteria. Lastly, the board has established a claims adjustment review panel comprised of representatives of the board, the medical staff, administration, and legal counsel to review and negotiate the settlement of claims. Accordingly, the board will not entertain comments on or discuss or negotiate claims at this meeting. I request approval of orders of the day.
Second.
All those in favor, please indicate by saying yes.
Yes.
No. Motion carries. Thank you. We now need approval of the minutes of the meeting of December 16th, 2013.
So moved.
We have a second?
Second.
Thank you. All those in favor, please indicate by saying yes.
Yes.
Those opposed? Motion carries. Thank you very much. And now we have a very interesting item on interventional oncology, bringing new options for cancer patients to Sarasota. Dr. Justin Stephen Lee.
Thank you, Dr. Malone. I am very pleased to get to introduce this month's speaker, Dr. Justin Lee. Justin attended college at Tufts University, followed by medical school at George Washington University. He completed his radiology residency and interventional radiology fellowship and research at Georgetown University, which happens to be the home of the Lombardi Comprehensive Cancer Center, the only NCI center in Washington, D.C. After serving as an assistant professor at Georgetown for 3 years, Justin joined our hospital staff this past summer. A recipient of numerous honors and awards, Justin has been invited to speak at both local and national meetings. Therefore, please welcome Dr. Justin Lee as he presents Interventional Oncology, bringing new options for cancer patients to Sarasota.
Welcome.
Thank you. Well, thank you for inviting me. I think the topic I'm going to talk about may be a little bit foreign here because interventional oncology is not necessarily a household specialty. My father doesn't even really know exactly what I do, but hopefully I'll enlighten everyone a little bit. Anytime I like to start a cancer talk, I think it's always good to start off with good news. And the good news is that over the years, since I've been alive, we've made great strides in terms of cancer therapy. We're kind of winning the war, so to speak. Our incidences are going down, our survivals are going up, and really that's because the population as a whole is doing things like lifestyle modification, We have better screening tests, and we have better treatment options. So if you look at this graph, which is a little bit busy, and we just sort of focus on the lines right here, this is just colorectal cancer by itself. And that green line there is the worst type that you could get. It's colorectal cancer that has distant mets, meaning it's beyond the colon. And if you notice, the graph on the left shows that the line is decreasing. That's the number of cases of patients who are actually presenting with distant metastatic disease. That's going down. That's a good thing. And then while we do know that distant metastasis or spread of the cancer outside the colon is very bad, if we look at that green line on the other graph on the right-hand side, that shows that our survivals are actually going up. And if you look at all the different lines there, survival's going up everywhere. And a lot of that is due to this. This is a very busy slide, but this is survival in that subset of patients in the green line who have very advanced disease. And if you were to pay attention to the right part of the graph there where it says BSC, that's best supportive care. That's where we were probably 30 years ago, meaning that if you were diagnosed with distant metastatic disease, you had 4 to 6 months to live. But all those little additional arrows as we go along are showing additions of chemotherapy, and basically the line is going up. So we're increasing survival for people who really 30 or so years ago only had about 4 to 6 months to live to somewhere around 24 months. But you'll notice that we're kind of flattening out. And so what I would attribute a lot of this to is the multidisciplinary approach, where we have a lot of different stakeholders that come to the table and bring all of the different treatment options and things that we have for cancer patients. So that would include our medical oncologists, surgical oncologists, radiation oncologists, diagnostic radiologists, and then interventional radiologists. And a lot of people might not be familiar with what an interventional radiologist has to offer in terms of cancer. Well, we're really there from the beginning to the end. So probably one of the most common things that I do is image-guided biopsy. So rather than having to cut somebody open to figure out what the diagnosis is, I do it all through a needle using their imaging to guide it. I'm the one that provides a lot of the venous access in order to deliver the chemotherapy. We do procedures, I won't get into it, things like portal vein embolization, which actually get patients who wouldn't be surgical candidates to surgery. We then manage a lot of the things like biliary tubes, feeding tubes, urinary drains that need to be done for patients while they go on their battle for cancer. We then provide local regional therapy, and then of course palliative pain management towards the end when patients have kind of lost the fight, but at least we're trying to keep them comfortable. But I'd like to focus on the local regional therapies because that's what makes me most excited. And this is where an interventional radiologist can impact survival. So really, we have a war chest of multiple minimally invasive procedures that we can do that can help address local regional spread of disease. And we're going to talk mostly about the liver right now because I could talk for hours here about all the different things we can do. But really, we break it down into two modalities that we do. One is ablation, which basically means we destroy cancer tissue by using a probe that can either burn or freeze the cancer. Or we do something called embolic therapy. That means we go through the blood vessels to deliver drugs or radiation using little beads targeting the tumors but sparing the normal liver. So if you look at the ablative technologies, and maybe some of you have heard of these things, I always tell patients we can freeze things, burn them, or electrocute them, and that's kind of what's represented on this cartoon. The radiofrequency ablation there, it's a probe we insert into the liver. It creates heat and burns the tissue. The one in the middle, cryoablation, that basically we create an ice ball in the center of the ice ball. We get it down to negative 40 degrees Celsius, which is lethal to cancer cells. And then something that's kind of new, something called irreversible electroporation, which is where we use electricity to shake the cells so that they lyse. And that product is called the nanoknife. And not pictured here is something called microwave ablation, which sits in the same category as radiofrequency ablation. We're about to perform the first microwave ablation next week here at SMH. And this is kind of what it looks like. So the top left-hand picture is a patient with ovarian cancer. Down in the bottom here, she has a metastatic deposit that was actually previously resected. Unfortunately, it recurred, and we got a PET scan, and the PET scan showed that that was viable active tissue. So the bottom left-hand slide there shows it what it looks like when we're doing it. I'm using CAT scan imaging in order to guide my probe to where that lesion is. And then in this case, we used cryoablation. And then the last little picture there in the bottom right-hand corner shows that there's no FDG activity there. There's no active cancer cells. You see kind of this big void, almost as if we kind of cut it out. But we actually did this through a 17-gauge needle hole, which is probably similar to the blood that they would, or the needle that they would use if they were donating blood. Okay, now we're going to get a little heady for a second. When we talk about embolic therapies, we have to understand that the liver actually has a dual blood supply, the portal vein and the hepatic artery. The portal vein is that big purple thing on the picture to the left. That actually brings 80% of the blood flow to the liver. But there's a second blood vessel called the hepatic artery, which really only does about a quarter of the blood supply of the liver. A tumor, when it sets itself up in the liver, actually only subsists on the artery, so we exploit that. The picture on the right shows an arteriogram. My catheter is sitting up in the artery supplying the liver, and you notice that right there, these little blush areas where it looks darker, that's showing you the hypervascularity of the tumor as it's established in the liver. And now this is a movie, if you bear with me for a second, that helps to explain it. This is what we do. So we bring the patient into our suite, we access the femoral artery in the groin, and we navigate a catheter up into the aorta, up to the first branch of the aorta that supplies the liver. And then when we bring this larger catheter to that spot, we then actually take a smaller catheter called a microcatheter, which is about the width of a piece of angel hair pasta. And we have some special techniques that we use to gain access very far out into the liver, to the blood vessels that are actually supplying the tumor alone. And from that position, then, we deliver beads that are loaded with chemotherapy or they're loaded with radioactive material with the end goal of trying to not only choke off the blood supply to the tumor, but also deliver high doses of chemotherapy or radiation directly to the tumor, sparing the surrounding liver. So this is an example right here. This is a patient who I've drawn a little circle around, a liver tumor that's up at the top part of the liver here. This is the lung. I don't know if you guys can see the mouse picture, but the lung is right up here. The heart is sitting somewhere right over here. So it's very high and kind of out of the reach for us to do an ablation. So what you see on the right-sided picture is my catheters in the liver. The microcatheter is going up to the single vessel that's supplying the tumor. And there again, you see that arterial supply to the tumor. You can make out that it's kind of a blush. And so what we do is we deliver our therapy, and this is what it kind of looks like at the end. You see a dense stain where that round tumor is. It looks very similar to that MRI picture. And then my angiogram shows just kind of a cast of what was remaining. And this is what we want to see on follow-up. On the top left-hand picture there, that's a hyper-enhancing tumor. This was a hepatocellular carcinoma in a patient. The top right picture is immediately after, when we got a CAT scan after, showing that dense uptake of the beads and contrast within the tumor. And then the bottom picture there is the 6-week follow-up MRI. And notice between the first MRI and the bottom MRI that tumor no longer shows enhancement. It's not white anymore. It looks like a punched-out hole in the liver. So lastly, this is another sort of way that we can do things in the liver, radiation therapy in the liver. Now, radiation is a technology that we use all over the place, breast, bone, brain, because it basically destroys tissue types of all different origins. But unfortunately, the liver itself has a low tolerance to radiation. In order to kill a tumor, for example, like a hepatocellular carcinoma, we have to give a very high dose of radiation, about 120 gray, but the liver only tolerates 30 gray. So you have this mismatch here. But there's a concept called brachytherapy. Brachytherapy means that we take the radiation source and we implant it in the tissue that we want to destroy, thereby sparing the surrounding tissue. So the tumor gets a high dose and the background tissue gets a low dose. There's a product called Surspheres. It's the only FDA-approved sphere that's actually loaded with radioactivity. And it's a very, very small particle that we can inject in the tumor, just like that little animation that I showed you. What we're doing in that sense is that we're trying to load up the tissue with a lot of these little beads, and because there's so many of the beads that are peppered all throughout the tumor, their collective radioactivity causes the tumor tissue to die. And so this is an actual slide showing that. On the right-hand side of the slide, you see these little purple dots. Those are actually the beads, and these are actually embedded in necrotic tissue. On the lower left-hand side of the slide, that's actually normal liver, and we get a demarcation that's as crisp as that line that's drawn through the middle of where we were able to destroy the tumor but preserve the liver. It's sort of setting up this picture. This is a CAT scan which shows the orange ring would be where there would be effective radiation, and the rest of the liver is spared. So this is a case, this is a 58-year-old male carrier who presented with a large pancreatic tail tumor and liver metastasis. He had the pancreatic mass resected. It turned out to be a neuroendocrine tumor, which is from a GI origin. He was started on systemic octreotide, but if there's not really a good systemic chemotherapy for this drug, for this cancer. So he was referred to us for liver-directed therapy. There's the big tumor sitting on the top part of his liver. So on the left-hand side, this is the angiogram from that case. So again, you'll see at the top part of the screen there, you'll see that dark ball that forms, plus a bunch of other little balls. Those are the tumors in the liver. We do a bunch of steps to get him to this point, but on the right-hand side, what you're seeing is a picture where we selectively have injected the radiation into that side of the liver alone. So it looks like a PET scan that you might see, but that's actually showing my treatment. And you can see that the preponderance of the radioactivity is in a rind right around the tumor. And this is him follow-up. The pre-treatment photo is on the left, and the post-treatment is on the right. This shrunk down very nicely. This is at 3 months. And basically, this gives us an option, another sort of thing that we can have in our quiver to aim at these types of cancers that don't have a whole lot of options. And it's been so kind of popularized, even though it's really not that widely available. We are now actually a hospital that offers this since I've come here, that there's a big multi-centered randomized trial which actually just finished recruiting as I left Georgetown, which actually looks at taking patients with distant metastatic disease who have colon cancer and randomizing them to both receive Surspheres plus standard chemotherapy versus standard chemotherapy alone. And we're looking in terms of our endpoints here at overall survival. And this data is expected to be out in 2015. So to sort of summarize, this is my vision, and this is why I took the job down here and I came here. I would really like to see us try to develop SMH into a regional referral center for cancer care. I mean, I think we can do this in a short amount of time because, and at a low financial cost, because as I've observed being here, I think a lot of the pieces already exist. We have a few action items. I think we need consistent presence at Tumor Board, and it's actually already just been enhanced, at least since I've been here, with a lot of the GI oncologists showing up. But there may be opportunities to parse out certain things. Right now, our Tumor Board, we talk about every cancer that's out there, with the exception of breast. If you come from a cancer center, we have a GI tumor board, head and neck and urology tumor boards all by themselves because they each have different things to talk about. We need to establish treatment protocols, and I think one of the ways to help that, and this is something that we did at Georgetown, is have something called a nurse navigator or a facilitator, which means it's a solitary phone number that a patient who has a referral with cancer kind of speaks to that one person, and they help to organize all the different players involved and get them to where they need to go. I think the advantages to the hospital are that we can provide advanced innovative care here locally. One of the things I hear a lot of is patients we biopsy end up getting referred up to Tampa, and I don't think that they need to have that done because I know for a fact a lot of the things are being referred to up there we can provide right down here. I think it would enhance our reputation as a progressive facility in the area, which would help to attract industry-sponsored studies such as SurfLox, which I'd love to do here because it brings money and prestige. I think it will increase the cooperation between the medical specialties. And then, attract additional subspecialty practitioners to the Sarasota area. And lastly, improve our hospital ranking. So that's kind of in a nutshell what I do. So thank you for the opportunity to present it. If you have any questions, I'd be happy to answer them.
Thank you very much, Dr. Lee. We appreciate your coming. And next, we have an Excel Award winner, Abby Moliterno, Supervisor, Heart and Vascular Services. Thank you again, Dr. Lee. We appreciate it.
As Dr. Malone said, our Excel recipient for the month of January 2014 is Abby Moliterno. She is a supervisor in Heart and Vascular Services, and she's been employed by Sarasota Memorial since August of 2010. Here are a few comments from Abby's peers. Abby is becoming an incredible leader. She always goes above and beyond in all she does and takes the initiative to complete a task or look into a situation, even if it's not her responsibility. She is a team player and plays an essential role to the success of the area she works in. I've had the pleasure of working with Abby for several years. She's a very knowledgeable and motivated employee. She's quick to learn, proactive, and able to work independently. Abby demonstrates a professional demeanor at all times. She has the respect of all her coworkers as well as anyone she comes in contact with. She has an open door policy and is always willing to lend a hand in any way she can. Abby is very professional in her handling of management issues. She takes the time to resolve any issues that should arise. She works with all her employees to find the best solution for everyone. She's supportive, organized, competent, and confident. Abby's rapport with patients and external customers is wonderful. She's one of the reasons so many of our patients rate our satisfaction scores so high. Abby recently graduated with her MBA and has been promoted twice. She's able to handle transitions well and has proved to be excellent in each role. She's an integral part of this organization, and we're very fortunate to have her. Congratulations.
Story. And we have a beautiful plaque. This is an employee recognition program, Sarasota Memorial Healthcare System. The Hospital Board and administrative staff of Sarasota Memorial Healthcare System are grateful to all employees who constantly enhance the quality of a patient's stay by making an extra effort in their daily activities. The Excel program is designed to recognize employees who distinguish themselves, superior performance and attention to others. Individuals recognized are models of excellence who strengthen the quality of a patient's care and the image of Sarasota Memorial Care System in the community. The hospital board and administrative staff are pleased to present this to you, Abby, with the Excel Award for January of 2014 in recognition of your demonstrated courteous and caring attitude and contributions toward excellence at Sarasota Memorial Care System. Gwen McKenzie, Chief Executive Officer, Marguerite Malone, Chairman of the Board. Congratulations.
I just was totally caught off guard when this was presented to me by my director, but I'm so thankful for the opportunities that have been given to me by upper management and my coworkers to be standing here today, and I couldn't do it without the nurses and support staff that I have on my team, so thank you.
Thank you. Next, we have the First Quarter Leadership Award. Teresa Michael, Director, Health Information Management.
This is Teresa Michael. She is the leader of the first quarter 2014. And here are a few comments from her nominations. Knowledgeable, positive, supportive, and nurturing are just a few words used over and over to describe Teresa. Teresa is smart, emotionally intelligent leader who communicates very effectively the key priorities and strategies needed to move the organization forward. Teresa has displayed tremendous leadership during a period of significant change in the HIM world. During the past couple years under her leadership, HIM's Clinical Documentation Improvement Program was developed, new code grouper software was installed, Medicaid coding to APR DRGs was implemented, and she is now a leader in the ICD-10 preparation, which is about to be implemented. All this occurred while improving customer service significantly. Teresa is a team builder in customer service. Frequent customer service issues have virtually vanished under her direction. Teresa has built a strong team of professionals who work well together. Teresa is always willing to go out of her way to train new employees about any topic she knows. This makes her an excellent mentor. She shares her skills and knowledge with all her staff and offers great support to ensure our success. She took the time to answer my questions with regard to papers that I was preparing for classes that I'm taking. Teresa has made it possible for several staff to change schedules and enable them to further their studies or care for a loved one. I've worked with Teresa on a number of challenging initiatives. She can always be counted on to devise creative solutions to complex problems. Teresa is steadfast in her management style. She always chooses the high road and encourages everyone to do the same. She's confident and quick in decision-making. She leads by example and manages her staff with compassion and integrity. Teresa participates in numerous charity fundraising events. She also volunteers her time mentoring for the U.S. Olympic archery team, being a former Olympian herself. Did you hear that? Twice, not once, but twice. U.S. Olympic archery team. We have a former Olympian. Thank you. Congratulations.
Okay.
Shows you. Okay, Leadership Award, a Leadership Award Recognition Program for Sarasota Memorial Healthcare System. The hospital board and administrative staff of Sarasota Memorial Healthcare System are grateful to all leaders who constantly enhance the quality of a patient's stay by making an extra effort in daily activities. Inherent in that leadership is the ability to enhance employee satisfaction and act as a role model to inspire staff to become the very best they can. As a role model, you have developed a department as a benchmark of excellence for the entire organization. The leadership program is designed to recognize leaders who have distinguished themselves by superior performance and attention to others. Individuals recognize models of excellence who strengthen the quality of patient care and staff satisfaction and the image of Sarasota healthcare system and the community. The hospital board and administrative staff is pleased to present to you, Teresa, with the Sarasota Memorial Healthcare System Leadership Award for first quarter of 2014 in recognition of your demonstrated leadership abilities, contributions toward excellence. Sarasota signed by Gwen McKenzie, Chief Executive Officer, and Mark Malone, Chairman of the Board. Congratulations.
One small clarification, I was the team manager. I didn't necessarily shoot the arrows.
Directed them though, right?
Yeah, I made sure they were there on time and, didn't stay out too late at night. Thank you so much for this honor. I was totally surprised. It takes a team, and I'm just a small part. Thank you.
Thank you very much. And now we have the report of the medical staff. Dr. Von Waldner, Chief of Staff.
Thank you, Dr. Malone. I have just one item of action for the board. It is approval of the criteria for emergency medicine ultrasound credentialing. This criteria has been reviewed and approved by the Medical Executive Committee, which recommends your approval.
I move approval of the criteria for emergency medicine ultrasound credentialing as recommended by the Medical Executive Committee.
Any comments or discussion? All those in favor of the motion, please indicate by saying yes.
Yes.
Opposed? Motion carries. Thank you very much.
That concludes my report.
Thank you. And the auxiliary report, Mr. Dutrell, President.
Thank you very much. At 7 a.m. this morning, the auxiliary-sponsored jewelry sale by Masquerade began and recently closed at 5 p.m. The sale will continue tomorrow from 7 a.m. to 4 p.m. All items for sale are $5, a very inexpensive way to obtain presents for friends and relatives. The sale is located in room 4A and B, adjacent to the Windows Cafeteria. On March 18th and 19th, vendor scrubs and stuff will return for a uniform sale. The auxiliary is planning to have volunteers working as a team in the cardiac section of the 7th floor of the courtyard tower. This will begin next month and last for 4 weeks. The teens are visiting patients, assisting in fall prevention, providing patient care and other duties. The volunteers will be guided by Lindsay Tuttle, cardiac RN. Lindsay was previously a teen volunteer who blossomed into a wonderful nurse. Her teen volunteer experience resulted in her mother also volunteering at SMH. That concludes my report.
Thank you very much. And now we move on to the Sarasota Memorial Healthcare Foundation. Ms. Alex Quarles, President.
Thank you, Madam Chair. Quick report today, just a reminder of some of our upcoming events. I hope that many of you can join us. The first one is going to be on February 28th, is our third annual Women in Medicine. It is a panel, a Q&A panel, and this year we have a very special guest, former Deputy Director of the FDA, Dr. Andrew von Eichenbach, will be here to talk about the political side of getting drug trials and technologies approved. Along with them on the panel will be Dr. Jim Schumacher, who obviously has had a lot of interest in his basic research at Harvard Medical School in Parkinson's disease, talk about his role in dealing with the FDA, and our own Kirk Volker, Dr. Volker, who's the chair or the director of the Community Medical Clinic. So hopefully you will be able to attend. We expect it to be sold out. The EPIC campaign, the Employee Partners in Caring campaign, will be started shortly, and the goal for the staff is $100,000 net. Something in your magazine that is in front of you that I think is interesting to point out is many years ago we gave a grant to Sarasota Memorial for $50,000 to start the Rothman Index, and it has turned into a very major publication. It has been published. We've actually been recognized, the foundation as being, and the hospital as being part of the startup of this amazing project, and we're really proud to be a part of that. We also have a great surprise of having Dr. Oz come here on March 28th. Invitations to that will be going out, and we will actually have sponsors who will have an opportunity to have a lunch with him in advance. So please consider attending that. Also, we have our annual mental health event funded by the Eiserman Family Foundation on March 29th. The speakers this year, last year we had Carrie Fisher talking about bipolar, and it is sold out. It is free to the public. It's at the Sarasota Opera House. This year we have U.S. Representative Patrick Kennedy, actor and author Christopher Kennedy Lawford, and author David Sheff. And definitely you should be there and get a seat, because it's always very interesting to hear some of the mental health issues that some of the celebrities that we tend to look up to. They deal with the same problems many of us do. We have an upcoming lunch for our legacy members. Dr. Concha is going to be talking at that, and actually I don't have the date in front of me at the moment, but you'll be getting an invitation to that. And it is for our legacy members specifically, but as you may remember, many years ago we made the first grant to the hospital that allowed the hospital to become the first in the state of Florida to have a center of excellence in stroke. So we're very pleased to bring that back around to everyone. And the last thing is that last week we had a board retreat. George Mongan was our facilitator. He is a specialist. He works with Fortune 500 companies in strategic planning, such as Mattel and FedEx and others, but now he's also working in the not-for-profit industry, really to help us with our strategic planning and our marketing efforts as we move forward to try and do more work and better work for the hospital and for the public. And unless there's questions, that's the end of my report.
Thank you very much. Now the Secretary's report, Mr. Tom Towler.
Thank you, Madam Chair. The board schedule for February is as follows. Tuesday, the 4th, we have a 7:30 a.m. board breakfast, an 8:30 governance committee meeting, a 9:30 HR committee meeting, and 10:30 an investment committee meeting. On Thursday, the 6th of February, we have a 7:30 a.m. PSI board meeting, an 8:30 quality committee meeting, and 10 o'clock the mission and planning committee. On Tuesday, the 18th, at 3 o'clock, we have an investment committee meeting, and at 6 o'clock, the public board meeting. On the 19th, part of the board will go to Tallahassee, and on the 20th, part of the board will go to Tallahassee with the management here. That's my report, Madam Chair.
Thank you very much.
Madam Chair,
Yes.
I have a calendar event to bring up before the board.
Go ahead, Mr. Virgilio.
I move that we return our monthly general board meetings and the related meetings on that date to the prior afternoon schedule, with the board meetings starting at 1 p.m. And I recommend, make this motion that it would be effective in the month of, this next month in February.
Second.
There's a motion that's been seconded to make this change. Is there any discussion or questions? If not, all those in favor, please indicate by saying yes.
Yes.
Opposed? Motion carries, so that means that we amend the February time that the secretary gave us to this new time of 1 o'clock. Thank you very much. And the treasurer's report, Mr. Joe DiVirgilio.
Alrighty. In regards to bad debt and charity care, I move approval of the bad debt and charity care for the month ending December 31st, 2013, in the amount of $12,526,000.
Any comments or questions about that? All those in favor, please indicate by saying yes.
Yes.
Opposed? Motion carries. Thank you very much.
Thank you.
And on to the operations report, Mr. Bill Wojin, Chief Financial Officer.
Thank you. Good evening.
Good evening.
I have the financial highlights for December, which is the end of our first quarter. So we have 3 months into our fiscal year so far. And for the system's operating revenue for the month of December was $45,509,000 compared to a forecast of $44,350,000. Fiscal year to date, our operating revenue stands at $133,203,000 compared to a forecast of $131,235,000. The system's total expenses for the month of December, $45,535,000 compared to a forecast of $45,359,000. For the fiscal year to date, which represents our first fiscal quarter, total expenses of $135,143,000 compared to a forecast of $133,568,000. Our operating income for the system in the rating agency format for the month, $2,340,000, which was an operating margin of 4.8%, compared to a forecast of $1,317,000, which is an operating margin of 2.8%. For the first quarter, we stand at operating income of $5,167,000, which is an operating margin of 3.6%, compared to a forecast of $4,623,000, which is an operating margin of 3.3%. For the hospital's paid hours per adjusted admission for December was 128, slightly lower than last December. For the hospital's operating statistics, and this is for the year-to-date, so 3 months in for the first quarter, average daily occupancy of 374 compared to a forecast of 358. Our admissions, 6,968 compared to a forecast of 6,259. Our average length of stay so far this year, 4.45, which is slightly lower than where we were at this point last year, 4.67. The hospital's surgery cases for the 3 months of the quarter, 4,801, compared to a forecast of 4,984. Births, 815, which is a significant increase over our forecast of 684. The hospital's outpatient registrations for the quarter, 97,892, compared to a forecast of 102,815.
emergency care center registrations, actual of 26,714, compared to a forecast of 24,351. Our case mix index for the fiscal year to date, for all patients, 1.62, and for Medicare patients, 1.74. Madam Chair, that concludes my report unless there's any questions.
Thank you very much. And we move on now to Jan Mock, Chief Nursing Officer, with wonderful news.
That's all I'm going to talk about. Surprise, surprise. Thank you, Bill. I do have exciting news to report today. It's been mentioned a couple times already in the service, but it's a very exciting time for Sarasota Memorial. We heard on Monday the 13th that we were awarded our third magnet designation. This is the highest honor in nursing excellence that you can achieve. It's a very prestigious designation, and today I want to talk to you and the community about what magnet designation means. The magnet vision is magnet organizations will serve as the font of knowledge and expertise for the delivery of nursing care globally. They will be solidly grounded in core magnet principles, flexible and consistently striving for discovery and innovation. They will lead the reformation of healthcare, the discipline of nursing, and the care of patients, families, and communities. The history of magnet is, and someone asked earlier, what does magnet stand for? So I'd like to just share that. Originally how it started back in the 1990s was they really wanted to look at what those excellent hospitals that were able to attract and retain nurses were all about. So they studied them, and they found that there were some key elements that are now the key elements of the magnet designation that really attracted or magnetized people to either stay or to come to their organization. So that's how the term started. The American Credentialing Center, or ANCC, developed magnet recognition program, as I mentioned, in 1990. They currently have 397 magnet hospitals, and this is not just within the United States, but this is internationally. They have magnet-designated organizations throughout the world. Only 50 hospitals, and as I say, we are now a member of the 1% Club. And that is, there's only 50 hospitals, or 1% of hospitals, who do achieve the third designation. And we received our first designation in 2003. Just a little bit about the magnet model, which I think very much aligns with healthcare reform and where we're going. But there are really 5 components of the magnet model. And we'll start with transformational leadership. There are a total of 88 sources of evidence that you have to demonstrate in the application and the designation. And if you're familiar with how many elements that is, it's really something to be very proud of. The first one they talk about is transformational leadership. And it really talks about the issue of strategic planning for nursing, how it aligns with the organization's strategic plan, advocacy and influence, visibility, accountability, and communications. The second one is structural empowerment. And they talk about, just a few under here, are professional engagement, how we really embrace the fact that our nurses are involved in national and state organizations. Nurses are engaged in their professional organizations and their professional development. Their commitment to the community and the involvement in the community, and the recognition of nursing. Under exemplary professional practice, they well define that each organization has to have a professional practice model and a well-defined evidence-based care delivery system. They have to be effective in their staffing and scheduling in the budget process. They have to have interdisciplinary, or what we call now interprofessional, care practices, and accountability, competency, ethics, diversity, culture of safety, quality of care, and autonomy are just a few. Under new knowledge, innovation, and improvement, we talk about research, which is very much part of our organization. They did recognize our research nurse, Jen Reingantz, as something that we should be very proud of and very set for the future. Evidence-based practice, which we talk about all the time, and innovation. And the last one that's in the center of this model is empirical outcomes. And we all know how important now, as we've always felt, but how important they are to everyone at this point, is the outcomes. And these, in this model, involve patient satisfaction, staff satisfaction, nurse-sensitive indicators like pressure ulcers, falls, infection rates, and those kinds of things. Just a few things about how it's nationally recognized. The U.S. News and World Report uses magnet designation as a primary competency indicator in assessing of almost 5,000 hospitals to rank report the best medical centers in 17 specialties. And in 2013, 15 of the 18 medical centers on the exclusive U.S. News and World Best Report in America honor roll, and all 10 of them in the U.S. News Best Children's Hospital honor roll are ANCC magnet recognized organizations. Just a little bit about our journey and our designation history. We went after our first designation in 2003. We were the 69th hospital in the country to be a magnet hospital. Our second designation happened in 2008, where we received our second designation. And yes, as you know, as I've talked for over 4 years, we did go for our third designation, or in the 1% Club. We submitted our application in April, and we submitted it for the first time electronically, which was a challenge, but we did accomplish it. Our application was 1,400 pages long and 2,600 pages of supplemental evidence. And as the lead appraiser said to us while she was here, this is like a PhD dissertation on steroids. It's extremely involved and really demonstrates what we do. Our site visit was held on November 19th through the 21st, where we had 4 appraisers here, and they appraised and visited over 30 patient care areas, both in the inpatient and outpatient world. They interacted with over 800 nurses, and including, and that was our physicians, and all of our interprofessional colleagues that work together to give excellent patient care. And the majority of those, they wanted to speak to only our bedside nurses. We did hear January 13th, a very exciting day, and we had a big celebration, and I want to thank those board members that were able to attend on quick notice for that wonderful celebration. Yesterday, I got the official report, and they really talked about the things that they mentioned at the phone call, but we did receive our third designation, but we also received it with exemplars. And I'm very happy to say that we received an exemplar in each one of the domains that I have described to you. One in transformational leadership and the ability for leaders to influence organization-wide change. Structure empowerment, how the organization addresses the healthcare needs of the community, and they talked about our community medical clinic and our breast center for taking care of the community that needs breast care that can't afford it. Under exemplary professional practice, they talked about the allocation and reallocation of resources to improve quality of care in nursing, and they also recognized us for coordination of care amongst disciplines and support staff. So you can see very strongly we're an interprofessional recognized organization. Under new knowledge and innovation improvements, the allocation of technology and information systems, and they highlighted our pilot and beta site for the Volt and how our nurses embraced it and really helped design that throughout for the whole country. So, and how excited the nurses are to use that for their communication plan. Whoa, going too fast. So at last, what are the benefits to you as a board, to us as an organization, and to our community? How it started, as I mentioned, and how the name came was attracting and retaining top talent. And I will tell you, every orientation I go to with nurses, almost the majority of them raise their hand they came here because it is a magnet organization. And I went there today, and that was true again today. Improve care, safety, and satisfaction, foster a collaborative culture, advance nursing standards and practice, grow business and financial success, and encourage professional development through lifelong learning, which enhances the quality of care. Whoa. Well, that last slide, which I don't want to mess with trying to get it back. But anyway, as you know, the billboards that we had up where we're stuck on our magnet nurses. Thank you, Bill. And these are just a picture of 5 of our 1,200 magnet nurses. And I would like to thank the board for their support, Gwen for her support, and the whole organization for their support. And I would like to have you also embrace with me recognizing our nurses for their great work over these last 4 years of gaining our 3rd magnet designation. Thank you. Anybody have any questions?
For those of you that were not able to be at this very exciting day, something Jan didn't mention is that they selected all sorts of remarks, particularly to Jan's leadership and to the way that she had supported the program and the example that she is, in addition to a lot of comments about how wonderful the organization is, too. And we all appreciate the support the CEO and CFO and COO and everybody gave to this. But clearly, you're a very exceptional leader, and we thank you very much for that.
Thank you so much.
We have no board reports, so we'll move on to committee reports. And the first committee report is Audit Committee, Mr. Darrell Henry.
Thank you, Madam Chairman. The Audit Committee met on 2014, 10/10 a.m. Lori Nissen and Jennifer Jenkins from Cape Finance Audits on September 30th, 2013. The report was very favorable. The letter noted no areas needing improvements. I'll tell you why that's. Unanimously recommended full board approval of the 2013 audit report. Thus, as committee, I move acceptance of the audits of the Sarasota County Public Hospital financial statements, the SMH healthcare retirement plans, as recommended by the audit committee.
Second.
Any comments or discussion? All those in favor of the motion, please indicate by saying yes.
Yes.
Opposed? Motion carries. Thank you very much.
Recommended cost benefit analysis. McKenzie advised the chair that the finance committee decides for return on investment, which we. Now, remember that comment I made about the letter said no areas needed improvement. That's due to our staff, Mark Thornton, Bill Wolchin, and Nelson Lee. Thank you all three. Thank you very much. Quite easy to promote. Thank you, guys. That's all I have, Madam Chair.
Thank you very much. Move on to Finance Committee, Mr. Dick Merritt.
Thank you, Madam Chairman. The Finance Committee met on January the 7th. Jim Young, Business Manager for Perioperative Services, discussed the ortho power equipment in the operating room. In the first quarter, there has been an increase in ortho cases. The volume is up and growing. The new power system is smaller, lighter, and the battery life is longer with the lithium batteries. They will be standardizing batteries. For the NeuroPower Striker NSE electric circs drill, these will save over $25,000 per year. They reduce noise, reduce OR setup time, there are no cords, and they are more user-friendly. Our current drills and batteries are approaching the end of life, and there are continual problems with power output. Therefore, I move the approval of the purchase of the Striker System 7 Ortho Power System and NeuroCernux drills at a cost not to exceed $983,000, as recommended by the Finance Committee.
Any questions or comments? All in favor of the motion, please indicate by saying yes.
Yes.
Opposed? Motion carries. Thank you very much.
Janet Stevens and Susan Grimwood discussed progress on the project of the API, which was approved in October 2011 for timekeeping, staffing, scheduling, and related productivity tools and analytical systems. Nelson Lane reviewed the original board approval of the system, and he noted that the project came in at $200,000 under budget. Janet discussed statistics regarding rollout of the project. There are 4 modules, staffing and scheduling module, and related productivity tools. All employees are using time and attendance. All of nursing is using staffing and scheduling, with 129 cost centers using for a total of 68%. Current utilization and benefits were reviewed, and in addition, a smartphone app is being used, as currently we are the only hospital using it. Diane Settle and our award winner, Teresa Michael, then advised us that we have been working on the ICD-10 project for 3 years. Now there are less than 9 months to go until full implementation of ICD-10. The team has done an excellent job in leading us. First Physicians Group has been brought into the group. The education platform is installed and in use. The physician educator has been engaged. We have performed the analysis of the DRG shifts and financial impact, and we believe that we will be ready to go in 9 months, and we thank the team profoundly for a lot of good work. And lastly, Bill Wojin gave our always wonderful Moody's 24-18 outlook, which has always been negative for the last 6 years and continues to be for not-for-profit hospitals, but we are doing better than most. So that is my report, Madam Chair.
Thank you very much. The Quality Committee is next. Mr. Bob Strasser.
Thank you, Madam Chair. The Quality Committee meetings are held in closed session, so I have nothing to report at this time.
Thank you. So we'll move on then to the President's report. Ms. Gwen McKenzie, President and CEO. Crisp.
You'd be really disappointed if this board report didn't come up, wouldn't you be?
We would.
You would. Good evening. This is our fiscal year-to-date December Sarasota Memorial Leader Report Card. This is our objective measures of the report card that we set as a management team and as a board each fiscal year, and we're now a quarter into our fiscal year. The service pillar, we have HCAPS, our inpatient patient experience measure. Our goal was to be really have all domains above the CMS average of 50%. And currently, we have 7 of the domains, clusters of questions as a domain, above the 50th percentile. Outpatient, with our 850,000 outpatient visits, we set our goal to be at the 83rd percentile of patient experience, and we're currently at the 81st. Our Gallup Employee Survey will be probably the month of April, so we don't have a report on that yet. Our merits on time, which is a joint commission requirement, required to be at 95%. We're at 99%. The quality pillar and its measures, value-based purchasing is the Center for Medicare and Medicaid's new system of withholding reimbursement to be sure that outcomes are of quality. And so we are currently almost perfect at 100% of our reimbursement. The organization percent of patient safety readiness is a series of rounding, interviewing, and auditing across the organization monthly by all the leaders to ensure that we're have the highest level of patient safety. Our goal is 95%, and currently we're at 99%. In infection prevention, this is a combined overall standardized infection rate of 3 different infection measures. Our goal is to be less than 1.0, and currently we're 1.08, so you can see we have some work to do there. The organization finance is an operating margin positive of 4.2%, which is our budget, and currently we're forecast to be at 4.3%. You heard the month of December was 4.8%. And in the growth pillar, strategic growth goals, inpatient admissions were designed to be above 25,000, and you can see we're almost 26,000, so we're quite a bit above our goal there. Outpatient registrations were designed to grow about 3% at 812,000, and we're currently at 810,000. With that, we'll go through a little bit of the detail. This is our HCAHPS, or Hospital Consumer Assessment of Healthcare Providers and Systems. We call this the patient experience. In December, we had 7 of the 10 domains above the 50th percentile. You can see the domains that were not: communication with doctors, responsiveness of hospital staff, and cleanliness. So we did drill down in those areas. Our responsiveness is actually 1 point away from the goal, but we've had steady improvement there. We had an improvement of 1 point between Q4 and Q1 of 2014. So we know, and this was a plan that you actually saw firsthand when you did your tour of the bed tower. The nurses explained to you the whole system of responding to call lights, and I think you were fairly impressed with their rigor around making sure that we do hourly rounding and respond to call lights personally in the room. So we do expect that to improve. In fact, our January year-to-date, while we don't want to take that home, is significantly better than the score that you see here. The quiet actually increased by 3 points from the last quarter to this quarter, so we're seeing steady improvement. While we're not there yet, we're seeing steady improvement. So we'll continue to work on that. In terms of our fiscal year-to-date 2014, which is the first quarter, we're also at 7 out of 10 of the domains being above the 50th percentile. Outpatient Press Ganey, and you can see the detail with which we measure that by area, and you can see the areas that are below the 50th where there are action plans for each one, above the 50th where they're striving to be even above the 83rd, and I'll point out the Sarasota Memorial ECC has steadily improved. While at 72%, they've steadily improved. And above the 83rd percent, you can see how many of the areas are actually at 99%. This is the first year that we participated in the Community Youth Development Annual Gingerbread Village at the Sarasota Mall. So we were pleased to do that. Our pastry chefs, most people don't think of hospital food as chef-oriented, but you know that we do have chefs and they do a wonderful job. And many of our neighbors actually come to our little restaurant, 1700 in the hospital here, because they think it's restaurant quality food. Here's our Chief Legal Officer, Carol Ann Kalish, and her family, Greg and Ben. They have done this for Williams Parker has done this for I don't know how many decades, not years. How many? 37 years. They have visited the pediatric unit and brought gifts to our children that happened to be here on Christmas Day. But this is Carol Ann and Greg and Ben and some of our nurses.
That's so great.
We just had the 2014 National Nurse Practitioner Week, and I know you saw in peer review how many nurse practitioners were credentialing as allied health professionals and physician assistants as well in order to continue taking good care of our patients. Something new. Boar's Head, who is a partner of ours, selected us as a partner to hold their annual symposium and their semi-monthly meetings with their reps and distributors from around the country. So they started that this month, and here's a picture of their meetings, which we love to be showcased. This was the National Council of Jewish Women in Power luncheon, and I want to thank all of you who attended to support me. It's always lovely to be there with you. This is our value-based purchasing measures by month, and you can see all of the greens. So we're making steady progress in our process of cure measures that we also call core measures. Jan gave a beautiful report, as she always does, on the importance of the magnet designation, but we cannot stop celebrating this. It was quite a day, but really the journey to this needs to be underscored, and I often tell Jan she's got 1,200 nurses behind her because she does, and thank you for recognizing her exceptional leadership, because if you were there the day, and some of you were, that we got the call that we were magnet designated, they did talk about the exceptional leadership of our chief nursing officer, and we probably wouldn't be designated without that. So, Jan, we really appreciate everything you do. Not going to stop celebrating. Sometime later this year, right? We were notified that for the 16th consecutive year, we were named as the top destination for healthcare in the region, earning a Consumer Choice Award. This is defined by the best overall quality, best doctors and nurses, and image rating markets throughout the nation. So we were pleased. National Research Corporation. I know we heard Dr. Concha talk at our recent quality committee, and I think all of you were really impressed by our comprehensive stroke program and its results for the community. I wanted to highlight this. This is something fairly new that we started in December. It's a transischemic attack clinic, because if you have a stroke, you're at higher risk to have another stroke. And so this is a clinic that will see the patients that are at high risk for stroke or who have had a stroke and at higher risk for a second stroke, and make sure that we work on all the things that we know to be preventive. So Dr. Concha and his colleagues started that in the month of December. Our muscular dystrophy neuromuscular clinic received a generous check from the Muscular Dystrophy Association, and you can see Dr. Haynes there accepting the check. And we received a letter from Governor Rick Scott because of our being named in the Tampa Bay Business Journal as one of the top hospitals. This was an interesting article that I just wanted to highlight for you. There's a lot of discussion about the lack of success or success of the Affordable Care Act, and I thought this was an interesting editorial because we're always struggling, and of course we're always impartial because we want what's best for the community. But this was an article that sort of tallied up the number of newly insured through the Affordable Care Act, and it actually turns out to be 9 million. So we hear a lot about 2 and 3 million registered through the exchanges, but I think it's hard to really see overall how many million Americans are newly insured through this Obamacare. And it's actually 9 million when you think about the children up to 26 that weren't insured before, the people who didn't have access because of pre-existing conditions, and those who signed up on the exchanges, and those who were able, in spite of the fact that our state hasn't expanded Medicaid, many states have. I think there's only 21 now that haven't. And that was double the number of those who signed up on the exchanges, the expanded Medicaid. So that sort of tallies up to the 9 million. Now, those of you who diligently go to Tallahassee with us know that we haven't stopped advocating for coverage expansion, and will continue to do so because we think it's very important for the 60,000 people who are uninsured in our community, because it would help insure about half of them. So we'll continue to advocate for that. That, I would just like to read a patient letter. I think this actually came to you, Mr. Towler, and you forwarded it to me. Dear Tom, our family gathered on Siesta Beach for a long overdue reunion. My youngest son, who has a long history of brain tumors, had a grand mal seizure. First responders, EMS, got him to SMH's emergency room. An amazingly fast and efficient ER staff provided initial life-saving efforts before moving him to an equally efficient ICU for 72 hours. I want to commend Dr. Fine, Ruffing, and Gamra for their compassion, empathy for the family, and grasp of the situation. ICU nurses among many I want to thank are Holly, Ted, and Danielle. Jeff is under the care of a world-acclaimed neurosurgery group at NYU Medical Center. His and his wife's response to SMH was one of complete confidence. I certainly share that feeling. Our family wants to thank you for the time and effort you have invested in making SMH a world-class medical center. One last note, in addition to excellent expertise, the staff provided the family with a steady stream of information, empathy, and patience, all so important in the healing process. Again, thank you for your efforts on all of our behalfs.
Very nice.
And that concludes my report.
Thank you. So we have nothing on the consent agenda. No public comments, is that correct? Legal matters, Ms. Caroline Kalish.
I have no report.
Thank you. There being no other business, this meeting is adjourned. Thank you.